First of all, what is different between the original SARS and the SARS CoV-2, which has made it into pandemic? As you know, the original SARS outbreaks, several outbreaks, independent outbreaks happened from 2002 to 2004. And subsequently, even a similar MERS virus had multiple outbreaks, but none of them actually went on to create a pandemic. And so, what is the difference? In fact, this is became more severe because this is a milder virus, and as milder in the sense that the mortality rates of SARS-CoV-2 are lesser. Not only that, a significant proportion of people are asymptomatic, up to 85% according to the latest figures. And most importantly, there is a pre-symptomatic phase of transmission. Pre-symptomatic means people becomes infective a couple of days before they develop symptoms. So even the symptomatic people can transmit before they develop symptoms. And the presence of asymptomatic infections and the ability of the asymptomatic people to excrete virus for long periods. In fact, now we know that they excrete longer than the symptomatic subjects. This allows the virus to travel widely through airline and modern travel mechanisms and spread it across the country and between countries. This is the key difference that has allowed this virus to become a pandemic. And another key feature of all SARS viruses, not unique to this one, is that they are capable of both droplet and aerosol spread, which also has significant implications. Aerosol spread clearly means the indoor transmission will be higher than outdoor transmission, and as far as droplets, there will not be much difference between indoor and outdoor. This is one key difference. And I would like to explain why the principles of social distancing and bending the curve, which is the most important, most commonly heard term, and what are the different effects of different interventions on bending the curve. A simple kind of model that we have heard all over the world all the time is SIR models, and we are seeing hundreds of SIR models which are being used to make all sorts of predictions that have been all over the place. Part of the problem is that this virus is so complicated and unpredictable between individuals that these models cannot work, or no model exists which can actually make any predictions. But these models are useful for understanding the effects of intervention. You change one parameter, you can know what happens. This is what I have done. So susceptible, infected, recovered means in the beginning, in a pandemic, all people are susceptible. Nobody has an immunity. If this is an old virus or there is a vaccine, there will be a proportion of people who are resistant, who are immune. And then some people get infected, they give to new people, and then they recover or die. So basically here, and so when you recover or die, you are removed from this group, and then you're no longer susceptible. And then so you have a peak of this. Finally, the epidemic will end when the new infections are less than the existing infections. This happens when majority of the people become non-susceptible, and there is a threshold after which it stops. And another key parameter that everybody talks about is the reproductive rate. Basic reproductive rate means if a person has an infection, how many daughter infections he creates. So the first person gives to say 3 people, and that each of them give to another 3 people. In such a situation, if the average number of infected person, that is a new infections from every, it is called reproductive rate, and it's called R-Naught. It's called R-Naught in a non-immune population. This is important. In a population has no immunity, the reproductive rate in such a population of all susceptible naive population is called R-Naught. Why? Because when the group has some level of immunity, the reproductive rate comes down because a certain proportion of the people you encounter are resistant to it. So this is where the herd immunity or whatever the immunity comes in. If half the people are resistant to it, it reduces by that proportion, the R-Naught. So if you can vaccinate and make a certain proportion of the people immune, you can reduce this R-Naught. But key thing to understand is that this R-Naught is not a property of the virus, and the infectivity of the virus is only a small parameter in it. In fact, the best way to understand R-Naught is to see it as a product of 3 parameters. One is N, the number of people you meet every day. P is the probability of the transmission. If you encounter a person, what is the probability that you transmit? Is it 50%? Is it 10%? Is it 20%? And this probability can be changed by our physical interventions like physical distancing, whether you wear mask, whether one person wears a mask, whether both persons wear a mask, or what type of mask, all this will affect the probability. And third is the number of days of infectivity. And N is the number of people you meet, is basically the kind of social network you have. You meet more people, you are more likely to get, and you are more likely to spread. So this helps understand social and physical distance. So the intervention N, that is social number, meeting less people can reduce the R0. Wearing mask can also reduce R0. The D you cannot change. It's a property of the virus. Maybe a future antiviral can do something about it. So these viruses have different R0s. Measles have a very high 11 to 18, and Ebola is 2. So SARS has, in the beginning, Wuhan, the R0 for SARS was, this SARS CoV-2 was 3.5 for its latest estimate. And once people use interventions like masks and social distancing, this has come down initially to 2.4 in the Western countries, and Indian figures around 1.8. Because we came late, we knew much more about the virus. So the aim of epidemiology is to control this R0 below 1 so that the disease does not propagate. So I created this toy model. Toy model in the sense you can't make any real life predictions, but you can use it to test the audience perception of different values. We can put it into this model and see what happens. So by changing 1 or 2 parameters at a time, we can understand the impact of entry control at the airports, use of masks, meeting fewer people, effect of vaccination, effect of testing. All of this can be tried out at your, I mean, you can tell me and I will put it and show you. So you see that in a SIR model, so in a non-susceptible, everybody is susceptible, you have a peak. That is, number of infection goes up, and then when it runs out of sufficient, then it peaks, goes down, and the fraction of people that get infected in a natural epidemic is called Z fraction. So it will never reach 100%, but if your R0 is high, it will reach nearly 100%. And now let's go to the, when that happens, you can delay the peak. This explains why different parts of the country have different peaks. Those who have fewer cases will have later peak. Those who have more cases in the beginning will have early peak. So the number of introduction does not affect the peak size. It only affects the timing of the peak. Now, what happens if you do extensive testing? Now, as I'm assuming that there is not any test, if you increase the number of tests, you can see that. So but if you test below a particular threshold, you will find that there's no influence. Suppose if you can increase test to very high level, in fact, testing alone can reduce. How? When you test and identify somebody, you are removing them from the pool of infective people. It is essential. It is effectively like isolation. By testing people, you can reduce the number of people who are transmitting, and therefore even flatten the curve and completely stop it. Now let us see what happens if you have vaccination. If you can say, I'm saying, if you introduce the vaccine, that can also so here in this scenario where that is 63% have vaccination, that is sufficient to produce herd immunity in this thing, and the epidemic does not spread. Now let us say 18%, the epidemic is back. And what if you reduce the number of people you meet? Reducing the number of people you meet also flattens the curve. Same by introducing mask. So each of these interventions can reduce the epidemic.
Thank you very much. Now I will request Dr. Ujjwala Ghoshal. She is the Chief of Microbiology at SGPGI, to tell us about the various tests which we are hearing about today.
Good morning, everyone. Today I'll discuss briefly about the lab diagnosis of SARS CoV-2 or COVID-19 disease. So before going into the lab diagnosis proper, because in lab diagnosis we'll be using different targets. So that's why this picture, and just to tell you what are the various targets. As you can see, it is all of you must be knowing that it is a RNA virus. It belongs to the family Coronavirus, in which there are various viruses are there, and this new virus that it belongs to, it is a beta coronavirus. It has an envelope that is an, as you can see here. So envelope, you can see it is an envelope virus. There are envelope virus, there are non-envelope, but it has an envelope, spherical, and the diameter is around 120 nanometers. It is club shaped. Then it has this is very important. It has this spikes protein, which is a very important target, and it is used in various tests. Then, and it gives it a corona or the crown like shape. Then, sorry, then there are various, there's a nucleocapsid, that is RNA, which is again used in various targets, RNA and the protein. So there is this envelope, there's spike protein, there is this, then there are hemagglutinin and esterase. So various targets, we will in various further slides, we will see what are the various targets that are used. So we will have some idea. And before I go to the test proper, what are the various tests? It is very important to use, to understand when to test, whom to test. Because nowadays, each and everyone is being tested without any indication, even if whether it is indicated, test is indicated or not. And that's why our positivity is so low, like less than 6%. In other centers, 1%, 2%. Why? Primarily because we are not tested where we should test. But each and everyone without indication, the common cold, any disease, you have to test for the corona. So it is very important. There are various guidelines, like guidelines from various agencies, WHO, CDC, ICMR. So I think it is very important that we stick to any of the guidelines, and we don't work on our whims and fancy that if I wish, so I will test, because that is creating a lot of problems. And if you look at the indications, it is very clear that there are at least 9 indications, and out of these 8 are related to symptomatic patient, that you test when the patient has symptoms. As you can see, all symptomatic individual with a history of international travel in last 14 days, all symptomatic contact of lab confirmed cases, all symptomatic healthcare workers involved in containment and mitigation of COVID-19, all patients of severe acute respiratory illness. So there is only one category of asymptomatic, and that is asymptomatic direct and high risk contact of a confirmed case, to be tested only once. This is again important, once between 5 and 10 days. And what we see in our daily practice, that we receive huge number of 1,000 samples secondary, telling that it is a low risk case. So there is no, just I wish to remind you that there is no indication of testing a low risk case. I don't have the time to describe what is low risk, what is high risk, but it is all the guidelines are there from ICMR and various agencies. Briefly, high risk are those who are in direct contact with the patient, positive patient, or their secretion, and all this is very much clearly defined, right? So kindly do not test where the patient has no risk or very low risk. Every day we are receiving hundreds of samples, and then they are being quarantined also, which is again very unfortunate. Then all symptomatic ILI who are coming from hotspot or containment zone. Then, and sorry, one more thing I wanted to highlight, that is the testing. In such setting, the testing should be done once between the 5 and 10 day, between these duration, whenever you want, because this is the average incubation period. And what we see in our practice, that the patient are being sent for the testing at day 0, day 1, and again 3 days, 5 days, 7 days, then 14 days. So from where these indications come, I do not understand, because there are no such guidelines nowhere. Then all hospitalized patients who develop ILI-like symptom, all symptomatic ILI among returnees and migrants within 7 days of illness. And they also say that no emergency procedures, including the delivery, should be delayed for the lack of the test. However, the sample can be tested for testing if indicated, if there are any of these indications. Now the various tests briefly. So tests are basically of 3 types. We have molecular tests, which are the gold standard. Tests are of 3 types, either the molecular tests, which are the gold standard. Then we have immunoassays, either the antibody detection or the antigen detection. So I'll discuss briefly about them because I don't have much time. So molecular tests, which amplify the genetic material or RNA of the virus. So the gold standard is RT-PCR. This is the gold standard for the diagnosis of the SARS CoV-2. Then we have other tests like TrueNat and CBNat, which are also amplification tests, but these are cartridge based. Then we have antigen detection tests, which detects the antigen or the protein. There are various formats, like it could be ELISA based, or it could be rapid test, or lateral flow immunoassays. Then we have antibody detection, which are obviously, as we'll discuss further, that it is not for the it is not meant for the diagnosis, but for the serological surveillance and other purpose. Then clinical sample, as you know, in most of the cases is in first, like in molecular assays and for the antigen detection, it is the respiratory sample, minimal, usually 2, or for RT-PCR, we take 2 samples just to increase the like oropharyngeal and nasopharyngeal swab, because if you use a single sample, the sensitivity is low. So as to increase the sensitivity of test, we have to take 1 oropharyngeal and 1 nasopharyngeal swab. Then for antigen detection test, oropharyngeal, and for antibody detection, obviously serum or the whole blood. Regarding the application of tests, both the molecular and the antigen detection test, it is meant for the diagnosis. When there is a suspected patient and you wish to diagnose, then these two are, you have to go for either of these, and I will discuss this also. But antibody detection is not for the diagnosis. It has some other purpose. So regarding the turnaround time, again, this is very important. It is usually, it varies from 6 to 8 hours or even more, depending on the number of the samples you have to do. And here again, when I say it is 6 to 8 hours, it doesn't mean that when you send us the sample, when we receive the sample immediately, like when you say that this operation takes 6 hours, that doesn't mean the patient comes and he's operated and he goes home by 6 hours. So similarly is the situation in our testing. Like in our test, we have various testing centers. So if you give a sample at around 10 a.m. in the morning, naturally it will reach us at around 1 or so, because the attendant or the person who is bringing the sample, he cannot take each and every sample, because he has to bring say 400 or 500 samples. So he cannot take single sample. So even if you give 9 and you will expect that we give results 6 hours, within the 6 hours, it is not possible. So that sample is going to reach us at around 1 or 2. Then each and every sample will be matched with the list. They will be provided a number. Then they will go to the testing room or the RNA room, which will again take 1 hour, more than 1 hour or so, because thousands of the samples are already coming from the districts. So maybe the persons who are collecting or doing this job, they are already busy. And once they finish the work they are doing, after that your number comes, and then it will go to RNA. Again, the RNA work is already going on for another samples, thousands of the samples. So when this number will come, I do not know. So it may again take 5 to 6 hours or more, depending. Like now we are having a pool of more than 7,000 samples are pending. So therefore, it is very important to, when I say it varies from 6 to 8 hours, it doesn't mean that you will get the results in 6 to 8 hours. It is for a single test. Similarly, TrueNat for usually TrueNat 2-3 tests. It is the same test, but it is again a molecular for the diagnosis of RNA, but it is you can say cartridge based. So it takes, there are 2 assays. You have to do 2 tests. One is screening test, and one is, again, first you have to isolate the RNA, and then there are 2 tests. One is screening test. If screening test is for all coronavirus. So if screening test positive means then it is negative. If screening test is negative, it is negative, right? So, but if the screening test is positive, it just means that there is some coronavirus. You don't know whether it is novel or not, it is SARS-CoV-2 or not. Then you have to perform another test, which will again take 40 minutes or so. So again, so it comes to around 2 hours or so. But naturally, it is in contrast to RT-PCR, it is a very low throughput technique. There are two type of machine. In one machine, you can test one sample, in another two, and at the most, in a machine, you can test 4 samples. So maybe when your sample reaches us, all the 4 are busy. So naturally, your number will come after 2 hours or so, or even more. So similarly, this times varies. Then the antigen detection test. Antigen detection test, it is said to be a point of care test. That is, it has to be done at the bedside. You have to, this is a cartridge based test. You have to take the sample and then you have to put it in the cartridge and drop of the buffer. So it has to be done at the bedside. That is very important because you cannot send it to the lab because the buffer it is stable only for less than 1 hour. So you don't have the time to send it to the sample and do the test. Now the infrastructure, these lab-based tests, they need BSL-2 and specific equipment. All the RNA-based tests, they need appropriate PPE because it is infective. Similarly, for antigen detection test, it is a lab-based. It is like initial step has to be done in BSL for the safety purpose, and rest of the process you can do outside. But antibody detection, again, it is both type. If you are going for the ELISA, again, it is a lab-based test, and it again will require BSL-2 and specific equipment, appropriate PPE. But if it is RDT, then rapid test, then it can be used as a point of care test. I'll skip the cost and other things. And nowadays these tests are available in everywhere. So then you see a term CT values. You get a CT value because it is a fluorescent based test where the RNA is detected based on the fluorescent dyes or the fluorescent probe. So sometimes you see a CT value. So what is a CT value? It is a cycle number at which the fluorescence generated within a reaction crosses the threshold, and the fluorescent signal, they are above the background fluorescence. And high CT value means less viral load, and low means it is reverse. So these targets I have already shown you, and these are the curves. You can see different colored lines depending on the dye, color of the dye you have used, and this is how it looks like. So there are there are various formats. Like we receive the samples from the ICMR, sorry, these kits from the ICMR, many of these. So sometimes they send various types. So like TrueNAT, there could be a screening test, and if it comes positive, then you have to go for screening test. But multiplexing is also available. Then as every test, though this is the gold standard, but few limitation that sample collection has to be proper. And if there is a too much delay, then degradation of the and if RNA has already degraded, then the lab cannot do anything. Then there are presence of PCR inhibitors, and if the virus has mutated, it creates problem. There could be false positive results either due to the cross contamination during sampling handling or specimen handling, or then the TrueNAT, I already told you a little bit. So it is important to understand that when you order for TrueNAT, sir, I have just 1-2 minutes. I will need 1-2 minutes. I'm just 2 minutes. Then for this viral TrueNAT, you need a special media. So when you order for this, kindly collect, because this VTM for RT, the media is freely available in all the centers. But for TrueNAT, there is a special media. It is called viral lysis media. Naturally, it is costly and it is a very limited amount is present. So therefore, you have to get it in centers we have given, but sometimes you have to get it from the lab. And you get it again shows whether the risk, first you have to see whether your test run is valid or not. And the results are shown as detected or for positive or not detected. And the manufacturer say it is one good thing about is that it is made in India and results are usually comparable to RT. But it is very important to understand that the viral load it can detect, it is as low as 10 in case of RT, whereas in TrueNAT it is as high as 486 copies. So it is very important to understand that why you are doing it. If there is no emergency, like you have to operate or the patient immediately, or the patient is having MI, then only you order for TrueNAT. Otherwise, if you have some time, you have 6 to 10, 8 to 10 hours, kindly order for RT and not for TrueNAT. So these are the revised guidelines, which I'll have to skip because of the lack of time. Then there are various other point of care tests which are available in the market, but all of these are based on same principle. Then something about the immunodiagnostic test, that's antigen detection tests and antibody. Regarding the sir, I told you. Then sir, yes, sir, antigen detection test. Just one line about the antigen detection test, then I leave. Antigen detection test, it is very important to understand that its sensitivity is very low, right? So though it is claimed to be a point of care test, but it can only, like, its sensitivity is less than, reported sensitivity is less than 50%, and in our hand less than 40%. So it detects the specific antigen, and if it is positive, it is fine if the patient is having the disease. But if it's negative, which is in most of the cases, then you have to go for RT. It has to be confirmed by RT. Then I will, because of the lack of time, so I'll skip this antibody detection, and otherwise also it is not for the diagnosis, but for the other purpose. Thank you very much.
Thank you. Now I will request Dr. Durga Mishra from Immunology Department to tell us about the pathophysiological effects of this disease on various organs, because we know that it is behaving like a multi-organ disease. So it's very important to know what its effect is on various organ systems.
Yeah, I'm sorry. We all know that this disease has caused widespread devastation across the world, and previous speakers have already covered the structure of the SARS CoV-2. What is important to understand is that there is this nucleocapsid protein, the spike protein, the M and E proteins. And the two key features of SARS CoV-2 structure are it's optimized for binding to the human ACE2 receptor, and has a functional polybasic furin cleavage site at the S1 S2 boundary with respect to the spike protein. This spike protein will come multiple times into the discussion, and hence it's important to understand what this is. So why is SARS-CoV-2 infection much more severe and fatal and causing a pandemic as opposed to the SARS and MERS? The main reason is that while SARS and MERS directly colonize the lungs, the SARS-CoV-2 initially colonizes upper airways and secondarily spreads to lungs in a small proportion of cases. And in many asymptomatic individuals, it can just colonize the upper airways and spread to other people. Therefore, it has a greater chance and is causing a pandemic. To briefly understand the pathogenesis, one must know that this mature SARS-CoV-2 virus with this S spikes binds to the ACE2 receptor, and another receptor is the neuropilin-1 receptor, through which it enters the cell. And there are certain proteins like AP2 associated kinase 1 which play a role in this, and it may utilize the cellular machinery to synthesize further virus particles. However, these virus particles have an immature S spike, which requires a cellular receptor called as TMPR SS2 for maturing. And once these are mature, they can further infect cells. Further in the cell, once it enters the endosome, it can interact with TLRs, TLR3 and 7, and stimulate downstream inflammatory pathways, as well as the TLR interactions and interactions with RIG and other interferon sensing receptors in the cytosol lead on to interferon responses, predominantly type 1 interferon responses. And once inflammatory pathways are activated, there results this cytokine storm in a minority of patients, releasing pro-inflammatory cytokines like IL-1 beta and IL-6. So with this diagram, we can understand overall the various therapeutic strategies that are being explored. Vitamin C, vitamin D have non-specific antiviral properties, and there are these certain molecules like cephoranthin and selamectin which have been found to be cytopathic in viral cultures. And all of you must be aware of the controversies regarding ACE inhibitors, because it uses this ACE2 receptor for entry. This AAK1 protein, which is involved in the entry of the virus, is inhibited by a Janus kinase inhibitor called as baricitinib, and RNA polymerase inhibitors remdesivir, favipiravir, and protease inhibitors lopinavir, ritonavir interfere with viral synthesis. Camostat mesylate is a TMPR SS2 inhibitor, inhibits the maturation of the virus particles. And endosomal interactions can be minimized by chloroquine and hydroxychloroquine. Again, these are areas of controversy. That's not my intention to talk about today, just to understand what are the various targets and why. And you have these molecules like baricitinib, which inhibits JAK1 and 2, which are involved in inflammatory responses as well as in the entry of the virus, and cytokine storm if you have. Then therapies like interleukin 6 blockade, corticosteroids, and other cytokine therapies, anti-cytokine therapies are also being explored. So what is the cytokine storm? Basically, after the viral infection, there is release of damage associated molecular patterns like HMGB1, and this results in activation of macrophages, neutrophils, and which release a lot of inflammatory cytokines. And this is what is causing the problem in severe COVID-19. So basically, in a very simplistic manner, the cytokine storm that we as rheumatologists and clinical immunologists, we see in macrophage activation syndrome. And what is occurring here is a kind of a localized hemophagocytic lymphohistiocytosis in the lungs. And this is resulting in predominant injury in the lungs. And just briefly, particularly for those who are treating these patients, these are the features of macrophage activation syndrome, classical macrophage activation syndrome, and these are features that you see in patients with severe SARS CoV-2 infections: cytopenias, abnormal liver function tests, coagulopathy, hyperferritinemia. So when you see abnormal liver function tests, don't get carried away. Don't think that this is maybe going to affect your treatment, because this is a part of the disease itself. Type 1 interferon responses are important for viral infections, and SARS CoV-2 results in decreased type 1 interferon responses. Mechanisms I cannot cover in this brief session, but you must understand that what this infection does is it retards antiviral responses. So another important feature is thrombosis that occurs in patients with COVID-19, and there are multiple reasons for this. There is endothelial injury, and as a result there is endothelial disruption, turbulent flow, activation of immune cells, activation of platelets, activation of clotting pathways. So all of these are multifactorial and contributing to thrombosis. Hence people are trying drugs like heparin, so that this thrombosis that is occurring, multiple microthrombi in the circulation, these can be reduced, and hence the features related to severity may come down. Finally, coming to immune therapies, this treatment with convalescent serum has received a lot of attention. What it does is it neutralizes viral particles. Particularly, the nucleic acid and the spike protein are less mutagenic, and hence these are targets for future vaccines, because the other two proteins that are forming the part of the structure, the M and the E protein, are highly prone to mutate. And this convalescent sera may help by neutralizing viral particles, but at the same time there is also a risk of antibody dependent enhancement, particularly when there are IgM antibodies. That is, the presence of these antibodies may actually help the virus to enter the cell. Hence there is a double-edged nature to the antibody response, and one must be careful and use it only in selected patients, particularly those who don't have protective IgG responses. To conclude, cytokine storm akin to a local hemophagocytic lymphohistiocytosis is responsible for severe COVID-19. Thrombosis could be partly thought of as due to the Werkow's triad, hypercoagulability, endothelial damage, and flow abnormalities. Dampening the hyperactive immune responses of host through corticosteroids, tocilizumab, and other immunomodulators may help in those with severe COVID-19. Plasma therapy to supply exogenously antibodies against SARS-CoV-2, therapeutic anticoagulation in view of thrombotic risk, and need to consider role of agents with endothelial stabilizing action, because it is the endothelial injury that is leading on to the thrombosis. Thank you.
Thank you, Dr. Durga, for saving some time also. And the last topic that we will discuss today is that which are the groups which are at high risk for this disease and why, and what are the outcomes in terms of mortality globally. So I have requested Dr. Aditya Kapoor from Department of Cardiology to discuss this topic.
Thank you, sir.
So I'll just briefly look at the outcome data from the world in terms of confirmed cases, mortality rates, brief look at where have the curves bent, and then finally come to what are the high risk groups and why are they at high risk. So if you look at the daily new confirmed cases as of yesterday, India is in the top rung along with parts of South America and North America. In terms of country breakup, we are at the top three, India, Brazil, and USA in terms of daily confirmed cases. If you look at the death rates, daily new confirmed deaths, we are somewhere in the middle, 500 to 1000, not at the top, unfortunately. Fortunately, sorry. And if you look at the daily new confirmed cases in terms of country, again, we are ranking at the very top. Per million people, if you break it up, we are at the middle area, 0.5 to 1, doing a bit better than parts of South America, North America, Russia, and Northern Europe. This is important. Where are the confirmed death rates increasing? So the middle column is the total deaths, on the right is the new deaths, and on the left is doubling rate. So if we look at India, as of yesterday, 30,000 odd deaths. New deaths, we are rapidly increasing, and doubling rate, if you see, we are amongst probably the top, 29 days. So 15,000 deaths on June 25, nearly doubling in the last 29 days. So that is again sobering data. Which countries are bending the curve? If you look at breakup of the continents, USA, despite the numbers, seems to have flattened the curve a bit. Europe, definitely countries like Italy, Spain are now down. UK and Russia are hanging in the middle. South America again upswing. Asia again, of course, upswing. So I've just broken it up country-wise as well. If you see India, Brazil, and USA, we are at the top. UK, Russia, again, they have not really flattened it till now. But countries like Italy, Spain, Japan, China are at the bottom now. Lastly, case fatality rates. Presently, we are around 2.4, 2.5%. Much better than other parts of the world. But again, that is as of now. So coming to high risk groups, I'll discuss three things. Age. There is no question that as the patient grows older, there is higher mortality. This is across the world, it has been shown. More than 60 is a bad sign. If you look at Indian data, on the left, if you see 30 to 60, we form about 1/3 of the share in the total population. And the mortality rate is around 40%. Unfortunately, more than 60 years, 10% of the total share in the population, but mortality rates are nearly 53%. So this chunk, more than 30, contributes to nearly 9 out of 10 deaths. Comorbidities is second factor, so age, comorbidities. Initial data from China showed us that cardiovascular disease, diabetes, COPD, hypertension, these were bad signs. So I pulled out three recent meta-analysis. Gender, age, smoking, hypertension, diabetes, cardiovascular disease, chronic respiratory disease. If you have this, the odd risks of dying is nearly 2.5 to 3.5 times. Lab parameters which tell us a bad sign is lymphopenia, altered LFTs, as I think Abel also mentioned, altered renal functions, high troponins, and high D-dimers. Recently, it has been shown that altered renal function at admission and derangements during hospital are all bad signs. So kidney disease on admission and development of AKI were adverse markers. So if you look at the CDC data as of June, strongest and most consistent evidence of bad comorbidities in the context of COVID, cardiovascular, chronic kidney disease independent of dialysis, COPD, type 2 diabetes, and of course other things like cancers, organ transplantation, obesity. Mixed evidence with asthma, cerebrovascular disease, hypertension, pregnancy, smoking, etc. If you look at the Indian data, this is a spectacular data. If you see on the left side, health risk or the risk from COVID, predominantly the red area is in the northern area, southern, and parts of eastern and western. And this is exactly replicated by where chronic diseases are higher, like hypertension, diabetes, CKD. So both the graphs match. So even Indian data tells us
that comorbidities is a bad sign. Why? Probably these are low immunity guys. Endothelial dysfunction is higher, as Durga also mentioned. Pro-inflammatory states are commoner, and primarily the mode of entry of COVID virus, which Durga described briefly and very elegantly, it is primarily mediated by the ACE receptor, and recent data also tells us by the DPPP4 receptors. So both these receptors help the virus gain entry into the cells, and both these receptors are closely involved in renal, cardiovascular, and glucose homeostasis. That is why patients of cardiovascular disease, renal dysfunction, and diabetes do badly. And this ACE receptor is expressed across all these organs, so that is why all these organs are affected. And recent data shows us that this virus is nephrotropic. It infiltrates into the renal cells, and cardiotropic as well, leading to myocarditis. Second, apart from age, comorbidities, the last thing is gender. Across the world, the data showed us the solid bars are the males and the dotted bars are the females. Males do badly. Initial data from the Integrated Disease Surveillance Program in India showed the same thing. 2/3 of the males, 68% was the contribution by the male gender to COVID mortality in India. But this is very, very interesting recent data from India, gender differential. The commonality was higher in males, we all know that, but the case fatality rate surprisingly was a bit higher in females. This is data from India. Now the gender differential initially was explained that males did badly because higher rates of cardiovascular disease, diabetes, chronic kidney disease in the males, higher rates of smoking, and we all know there is a protective and differential immune response mediated by the gender hormones, by the estrogen. So that is why perhaps the females did better. There is a differential expression of the ACE2 receptors in the females. So that is why they did better. But the hypothesis that why Indian females do badly, a recent editorial in Lancet in response to that paper said that perhaps the nutritional status of the Indian females was worse. They were anemic, poor physical fitness, and the fact that probably due to their more contribution to the household work and environmental conditions, they sought medical help late. So that is again, one thing which needs to be explored. So to conclude, any of these comorbidities is a bad sign. Age and gender is a bad sign. We as clinicians need to understand the high risk groups, which will have a bad outcome in terms of hospitalization, ICU stay, and death. Clinicians need to understand this, inform the patients also what is their level of risk. And the future, what does it hold for us? We need to understand more mechanistic explanations of why these comorbidities contribute to bad outcomes. Is gender really an important driver of the risk of mortality? And we need to understand more facts about the biology and gender norms which are going to shape the outcomes of this pandemic. Thank you.